going through the airway algorithm. So theoretically, we got the airway secured now. Let's move on to some post-intubation management. I know this protocol really only applies to paramedics, but I think it's important for EMTs and advanced EMTs to know what your partner may be doing. So it's very important that any patient that is intubated receive analgesia and sedation, especially if you work for a service that does RSI and gives paralyzing drugs. We don't do that at Ambulance Inc. currently, but those paralytics can last for up to 60 minutes depending on what you give. So um, I can't imagine laying there being paralyzed. You also, and just the general patient, wouldn't believe like how big a difference it makes for a patient to have a little analgesia on board with sedation. I had several patients over at the hospital where the ER docs would have them on a sedation-only drip like propofol or diprovan, and then the ICU doc would come down and put them on a fentanyl drip as well, and the patient would just be doing so much better. Like they wouldn't be fighting the tube anymore, and they would be compliant with the vent a lot better. So it just is better for your patient if they get analgesia and sedation. So our options are going to be, you can do a fentanyl bolus, 50 to 100 mics every 30 minutes as needed. You can also do a fentanyl infusion if you've got an IV pump at 50 to 200 mics an hour. Ketamine, you can do a bolus of 0.5 to 1 milligram per kilogram ideal body weight every 20 minutes as needed. Or you can do an infusion if you've got an IV pump at 1 to 2 milligrams per kilogram per hour. For sedation, critical care medics only can do propofol infusion at 27 or 25 to 75 mics per kilogram per hour. Versed, all paramedics can do bolus of 0.05 to 0.1 milligram per kilogram IV every 30 minutes as needed. Vent settings, we already had a vent protocol at Ambulance Inc., but this is going to be the state protocol for vent. Your initial vent setting for your rate, you should be between 12 and 15 breaths per minute generally. You want to titrate that to an end tidal between 35 and 45 unless you think the patient might be in some kind of shock or acidotic state. And if that is true, you do believe they're in a shock or acidotic state, you want to match the patient's spontaneous respiratory rate or set it at 20, whichever is higher. Because if they were breathing that fast, they were compensating for something. So you have to continue to help them compensate for that. Tidal volume is going to be 6 to 8 milliliters per kilogram based on ideal body weight. PEEP is going to be initially set at 5. FiO2 is going to be initially 100%. You can titrate that down to maintain an SpO2 between 94 and 99. Again, you don't want your patient satting at 100% because you really don't know what their arterial fat is at that point. If using a BVM, set the initial PEEP to 5. Titrate the O2 flow rate to maintain SpO2 between 94 and 99. Tidal volume should not be a full bag, just enough to see the chest rise, and then the rate, you're going to be the same as what we just said for the vent. As far as monitoring these patients go, you want to do continuous monitoring of the blood pressure. You want to do the cardiac monitor, SpO2, waveform, and tidal. They are all mandatory for intubated patients until they've been transferred to the receiving facility's monitor. So if you intubate a patient on scene, you have to keep them on your monitor until you move them over to the hospital bed and put them on the hospital monitor. You want to confirm placement of the ET tube, including auscultation of breath sounds and end-tidal CO2 after any significant movements or change in patient condition. Waveform end-tidal capnography is the current standard for tube placement and airway device confirmation, and monitoring must be used for confirmation and continuous monitoring on every advanced airway or intubation. So that's all iGels and all ET tubes that get placed, and you really should be using it when you're just using your BVM on your patient. So all provider levels, EMT and above, can use end-tidal waveform capnography for airway placement, confirmation, and monitoring. So everybody should be using end-tidal on every advanced airway they place.